Everyone for being here. Thanks, Stephanie, for helping us develop this session. I'm Shilpa Gupta. I'm a medical oncologist at the Cleveland Clinic and joined by Dr. Ashish Kamat, urologic oncologist from MD Anderson. And we are really excited to hold this session for the first time about young onset bladder cancer. And we'll cover different aspects of this cancer in our younger patients. Historically, it's a disease of older white men in their 70s, and we are seeing that shift a lot, and younger patients have unique challenges, unique problems, and a long life and journey ahead of them. So we thought this would be really great to build this session and learn from some other experts here about how they're tackling this disease in young onset disease in the colon cancer world, and learn about the genomics and what are the unique challenges we face. So Ashish, do you want to?
Yeah, no, I want to thank you all for being here. I think it's like, in my practice, I used to obviously see 70-year-olds, then 50-year-olds, then 30-year-olds. Now I'm seeing my last patient that with bladder cancer was 17, right? And it used to be, at least when we were doing our little limited analyses, and not sure you've done some work on this, right? It used to be lower grade tumors in the younger patients. Now it's flipping in the very young patients. It's ending up being high grade tumors. So it's really something that if we are going to be in this field for a while, and we all will be, we're going to need to not only address the needs of the patients, but also the needs of our therapeutics, right? Most clinical trials don't have patients under 18. They just don't. And most clinical trials have older patients because that's the patient that comes for clinical trials. So do the same drugs work in the younger populations? Are the pathways different? And just a little background for those of you that might be new to the think tank and workshops like these. These started 19 years ago when I was first involved, and they used to be small and really like 2 or 3 at a time. So it allowed people to be in a working group and actually take ownership of the project from start to finish. This is a little bit different, right? There's so many people here, 340 this year. So there's a lot of different working groups, but the fact that you're here and interested implies to us, as we're fortunate to lead this, that you're interested in this topic, right? So we're looking, and some of you sent us some topics for discussion. We're looking for ideas from you that we can actually translate, not just from this working group to just, oh, we had a good time, but into projects, whether it's clinical trials, white papers, anything that you want to move forward in the next several months. So keep that in mind as we have these discussions in the next hour and a half or so.
And also want to add, just like the mission of Beacon is everything is centered around the patient, we have our patient Brent, who talked about his journey yesterday in the opening session, and we'll again share some of the unique aspects of his journey. And we have 2 other patients who will share their story. Unfortunately, one is not doing very well clinically, so she may not join on Zoom, but we have a video recording that we'll share with you after this. And without further ado, I will first invite Dr. Ben Schlechter from Dana-Farber Cancer Institute, and he's not a bladder cancer treating physician yet, but hopefully he may become one. But they've been leading a young onset colorectal cancer program at the Dana-Farber for many years, and we thought it would be great to learn from our colleagues as to how we can follow their footsteps.
So we're going to talk about colorectal cancer really as a model for young onset cancers. In terms of background, I'm a member of a young onset colorectal cancer group. There's a subset of us who see these patients clinically, and then I lead our clinical trials in next generation immune therapies. So CAR therapy and immune checkpoint blockade, the next generations, which is cool stuff, and always happy to talk about that as well. My disclosures, I serve on the advisory board for Genus, and I've also worked with Janssen. So we're going to talk a bit about the incidence of these cancers in young onset patients, outcomes for these patients, the genomic profiles that we've been able to sort, and some of the exposures that are associated with this group. What I'm not going to give you is a conclusion because we don't have it yet, but I'm going to try and give you the information that we have that I think will generate some hypotheses and areas for research. So we should start with a definition of young onset colorectal cancer. So the important thing to know is our definition is conventional. The reason we define it as age less than 50 is that was the conventional screening definition, screening age of colon cancer until 2020. When we talk about young onset colorectal cancer, we're not talking about all the cancers of the colon, we're talking about microsatellite stable adenocarcinoma. This is the most common cancer of the colon. It's not associated with familial syndromes. For example, those are their own area of study in colorectal cancer. These definitions are changing. The screening age in colon cancer has dropped to 45, and we're learning more about the biology of these cancers, and there may be reasons to think that the definition should move still further. So colorectal cancer has been a story of success in patients over the age of 50. So for 40 years, we have seen a substantial improvement in colorectal cancer incidence and outcomes. And yet, if we look at the under 50 age group, we can see that every year since 1990, there's been a 1 to 2% increase in the incidence of colorectal cancer in adults. And this is not just an American problem, this is a worldwide epidemic. So data out of Australia, New Zealand, Canada, and the US has shown that screening is a substantial improvement in outcomes. On the lower part, if you look at the upper bars, there's an uptick in all of these countries in young-onset colorectal cancer. Location matters, just like in urothelial cancers, upper tract, lower tract, and bladder are different diseases. Rectal cancer, left-sided cancers, right-sided cancers are different diseases. As sort of an anatomy reminder, the colon takes in liquid stool from the small bowel and then concentrates it by removing water, and then you store dehydrated stool in your rectum. The consequence of this is that there's a higher bacterial load in the rectum, and there's different exposures throughout the colon that are an ingredient. When we look at this, we can see differences in sidedness and in ethnicities in terms of the outcomes of colorectal cancer. So right-sided cancers, so-called Bladder cancers, are rising to a small degree, in particular in the white population in the United States, whereas left-sided colon cancers are substantially increased in all populations, and that's where we see the most dramatic increase. Part of the reason that's relevant in the young-onset population is the morbidity of treatment. Rectal cancer is treated with intensive therapies that result in sterility, bowel dysfunction, permanent ostomies, and are really life-altering at the time of your life when younger patients are having children, when they're most productive economically. So it's a real impact to address these things in these patients. In addition, rectal cancer is rising much faster than colon cancer, and rectal cancer also is more lethal than colon cancer. What we have noted additionally is that while during the screening era of the past 40 years, colorectal cancer mortality has improved, young-onset colorectal cancer is actually having an uptick in mortality. And if we look at this across many diseases, we can see that colon cancer is the fastest rising cancer in adults in the United States. And in fact, by 2030, colorectal cancer will surpass breast cancer as the leading cause of cancer-related mortality in women under the age of 50. And in 2023, it surpassed all other cancers. It's now the leading cause of cancer-related death in adults under the age of 50. So this is clearly a substantial problem. If we look at the proportion of these, we also see some additional challenges. So colorectal cancer in young onset in 2010 accounted for 5% of all colon cancers. It's more than doubled by 2030. We look at rectal cancer, the most morbid, the worst outcomes. The most mortality is 50% more mortal, more fatal than colon cancer. Went from 9% to 22%. And if you zero in the under 35 population, you're going to see a substantial more than doubling of rectal cancer compared to colon cancer. Unfortunately, the way these patients are diagnosed is also problematic for outcomes. So almost half of patients wait 6 months before seeking attention, either rectal bleeding or change in bowel habits. And so they wait to see a doctor because poop is yucky and people don't want to talk about it. Most young patients require multiple MD visits before they're actually successfully diagnosed. In the pre-COVID era, it was around 2. In the post-COVID era, we think our data is going to show greater than 3 visits before a successful diagnosis of a young-onset patient. And unfortunately, also in the underage population, 2/3 or nearly 2/3 of all patients are advanced or locally advanced disease with the worst outcomes. This is the flip side of the over 50 population, where in fact these are substantially more uncommon. We now know from retrospective data that young onset patients receive more therapy. They're more likely to be treated in an academic medical center, they're more likely to receive postoperative adjuvant chemotherapy, and they're more likely in the advanced disease setting to receive multi-agent chemotherapy rather than single-agent chemotherapy. This has translated to no benefit. So if we look at survival for young onset patients versus average onset patients, there's no change. And if you zero in on a subset of populations, the adults under the age of 35 diagnosed with colorectal cancer receiving more therapy and are more likely to die and are less likely to be cured. Now if we look closely at these data, you'll see the under 35 population have a median overall survival for all stages of 21 months compared to 26 months for older adults, and the PFS of first-line therapy is 9 months versus 11 months, so a real substantial difference in outcomes for patients under the age of 35 in particular. And so that actually should be the definition we use, but we still use 50. So The question we are asking now in the Young-Onset Center at Dana-Farber is, what is this? Is this the same disease, just younger? Or is this a different disease with different biology? What's going on here? So we have some data now. So there's been a number of next-generation sequencing efforts to look at young-onset patients retrospectively. We've identified certain genomic profiles that are different in the young-onset population compared to the average onset population. They're more likely to have KRAS mutations, MAP kinase mutations, which confer resistance to a variety of therapies. They're more likely to have adhesion molecule pathway mutations, in particular APC, somewhat relevant in bladder cancer, but to a lesser extent. They're less likely to have a mutation of a gene called RNF43, which actually is a bad news mutation. They lack that mutation and yet do worse. An interesting observation was made in a clinical trial called CALGB SWOG 80405. This was a trial published in 2007, and it set the standard even now for standard therapy and first-line palliative treatment for colon cancer. It was standard chemotherapy with 2 different monoclonal antibody therapies. It's a negative study. There was no advantage to these various treatments. But the important thing about SWOG 80405 was those patients all had archival tissue stored. And now, 15 to 20 years later, we're going back and testing those. And so a large effort was undertaken to perform next-generation sequencing on these 877 patients. What we observed was different mutation profiles in black patients versus white patients in this cohort. The reason that's relevant is that black population from 20 years ago has the mutation profile that we're now seeing in the young-onset patients of today. This has not been shown in all data sets, but it's a really compelling observation that there's a time lag bias, there's something happening over time. We have to be cognizant of what this means. So it could be that we need to think about a time exposure, so something has happened that's moving from one population to another. It could be urban versus rural, it could be some other new onset, but we have to be careful when we interpret these data and data sets. We have to look at the date the tissue was drawn. So data of 20 years ago may actually have a different mutation profile of data of today. That also tells us this has to be an exposure. This is not necessarily something which is a heritable problem. This is an inflicted problem. So what else do we know? Besides this genomic change, we know there's certain other observations. We know that obesity is associated with cancer, more or less all cancers, with maybe the exception of endometrial cancer. When we look more closely at the Nurses' Health Study in our group, what we have observed is that patients who have the greatest weight gain after the age of 18 have the greatest risk of young-onset colorectal cancers. So a 40-kilogram weight gain after age 18, which is like 90 pounds, as like a doubling of risk of young-onset cancers, for example. We've also looked at sedentary behavior, also using the Nurses' Health Study made out of Europe. What we used as a proxy for sedentary behavior was hours watching TV. Retrospective. This was recorded in Framingham and Nurses' Health 1 and 2. And there's an observation that children between age 13 and 18 who are watching more than 14 hours of TV a week are more likely to have developed young-onset colorectal cancer. And there's lots of hypotheses. It could be these kids using less of their energy, there's some metabolic effect. It could be they're more constipated and kind of sitting on their carcinogenic stool and not getting up to go to the bathroom because they're watching TV all the time. I don't know if I like that or don't like it. It could be there's some other secondary exposure. Kids who are out in the sun might have a different immune environment than kids who are not out in the sun. Whatever it is, we can see the trend. We don't know the trend of the meaning. And then one of the other findings out of work done in Spain and also in the Nurses' Health Study was the number of sugar-sweetened beverages that children between 13 and 18 are drinking. So greater than 2 servings a day of sugar-sweetened beverages, soft drinks and sweetened drinks, is associated with a greater risk of colorectal cancer. And our most recent finding, actually published just this past month, is a really interesting and troubling one. So we looked at the impact of prior breastfeeding on colorectal cancer risk, and this actually was very hard to publish. And what we observed was that people who were breastfed as children are more likely to have high-risk adenomas, precancerous lesions, as young adults, and more likely to have colorectal cancer even in late adulthood beyond the age 50. And so you have to think about what this exposure could mean and what it is that breast cancer is conferring as a risk. Now keep in mind, breast cancer or breastfeeding is still the right thing to do if it's feasible for you. This is not a reason not to breastfeed. But breast milk is a highly concentrated substance that has a series of soluble agents in it that are then consumed and probably set off some sort of lifelong cascade of events that may be associated with colorectal cancer. So the solution is not to not breastfeed. The solution is to get that thing out of breast milk. So how do we interpret these data? I think we have to be careful when looking back at rectal cancer versus colon cancer. We should not average all of these cancers together, and that substantially confounds data. This is going to be a problem in upper and lower urothelial cancers. Be very careful with racial and time effects. So as we look at these populations, what may be present in one population will change over time, and exposure now is not the same as an exposure previously, so birth cohorts and geographic cohorts are important. The issues of obesity and sedentary lifestyles are hard to interpret, and the breastfeeding data is actually very compelling that there's an acquired risk. What can we do to help? Well, it turns out vitamin D exposure may be protective. Again, looking at the Nurses' Health Study, those with greater vitamin D intake are less likely to have young-onset colorectal cancer. Whether this is a protective effect of vitamin D or an associative effect that kids who play outside or who are more likely to be given vitamin D intake in their food, something like that, that's protective, it's not known. Ultimately, we have a complex interaction here. There's a cancer development that's related to various factors. We believe there's a gut microbiome effect. We haven't shown that just yet. There are dietary effects, there are metabolism effects, and we don't know yet. I would say at this point what we can say about this young-onset model, this is the leading model for young-onset cancers, is it's on the rise. That young-onset colorectal cancer is really, I think, a public health crisis at this point. Left-sided cancers and rectal cancers, the storage cancers, where this is most relevant, again, speaking to the issue of bladder cancer. Intensive therapy does not mean better outcomes. It's actually possibly inferior outcomes. There are significant differences genomically, and we suspect this starts very, very early in life, as early as breastfeeding. And we think that there are certain dietary and lifestyle effects that are affecting it, and we're hoping that vitamin D is protective, but we don't know yet. And there are trials underway to look at the role of vitamin D in colorectal cancer. So there are many people to acknowledge, in particular Kimmy at the top here. Kimmy founded the Young-Onset effort at Dana-Farber now almost 10 years ago, and this has become a very well-funded and impressive effort that is working throughout the world now. We have work going on in Spain, West Coast, East Coast, and hopefully we'll get some answers for you with time. Thank you.
If you don't mind, we'll take questions, as we go along. We'll keep it informal, right? So any questions?
Yeah, so we're looking actively into microbiome. We actually have already shown that the microbiome of colorectal cancer patients is different than non-colorectal patients, and there may be different profiles in the young onset patients, both for microbiome and actually for methylation status, and some of those methylation statuses are associated with preservatives, nitrate-laden foods, things like that. So methylation status and microbiome are underway, and hopefully we'll have some info on that soon. But we already know there's a different microbiome for cancer patients broadly.
So what aspect for me is, this is from the Nurses' Health Study, it looks like a univariate analysis.
Mm-hmm.
Have you done a multivariate analysis to see what falls out?
Yeah, there's a wide variety of work being done from the public health school. Actually, a lot of these are multivariate analyses. So yes, it's being done. Yes, a lot falls out. The ones that are most apparent are the ones that we published so far.
Are there correlates that you've taken from this that can be applicable to other tumors such as cancer?
So unfortunately, we don't have a lot of biological correlates from that. Everyone wants a piece of that, so to speak. But hopefully some of the large public health work done through the public health school at Harvard and other places will be able to give us that. So tissue from Framingham Heart Study, for example, Nurses' Health Study, and the Physician's Health Study. Additionally, I think it's really important to get archival tissue from the old clinical trials. A lot of the Alliance studies have tissue that's 20 years old. With modern NGS techniques, we'll be able to identify different patterns then versus now, which I think will also be important.
What's our path to opening up screening for patients under 45, especially with the less invasive options available now?
The short answer is I don't know. We have to be careful with the less invasive options. So a lot of like the new Garden blood test and the stool test, which is, wow, Cologuard had a little brain freeze there, poop in a box. Those are tests that were developed in older adults. And since we're already seeing different patterns of mutation and methylation in these adult patients versus younger adult patients, it may be that those are going to have a higher false negative rate or false positive rate in young onset patients. We actually have to study that population to know if that's feasible.
To that same end, since you presented data, this is essentially a genomically distinct entity.
Mm-hmm.
Do you think that sort of calls into question current treatment paradigms and the need to redesign clinical trials focused on what may be the best sequence or agent for younger people? Because it looks like, from a personalized medicine standpoint, really our legacy treatments may not be appropriate because of different genomic signatures.
I feel like this is one of those where I just say yes.
You could say absolutely yes.
Taking it a step further, I mean, is that part of the larger discussion in terms of trial design as we had this explosion of agents across?
Yeah, I think it's age independent. So one of it probably has to do with EGFR inhibitors, which are a subset of effective agents in older adults. Younger onset patients are less likely to have mutations in RNF43, which confers resistance to EGFR. So it could actually be the miserable old EGFR drugs that make everyone kind of rashy and itchy and diarrhea actually are better for young people than older patients, and maybe those are going to come back as a better agent. And maybe that DNA damaging agents and conventional chemotherapy are more problematic. We have to think of it in two ways. Number one is the effect of the cancer. So they may be more resistant to chemo for some reason. That has to do with how you develop the cancer. They may be harder for patients. So a thing to keep in mind for chemotherapy is the penetration of chemotherapy into the tumors via the neovessels. And those are whatever, 3 to 8 years old. The penetration of chemotherapy into your brain and your heart and your lungs is the age of your blood vessels in the brains and your hearts and your lungs. And so it may be that penetration of chemotherapy into normal tissue in younger adults is greater, which results in greater toxicity, and maybe there's dose adjustments that undercut benefit, whereas penetration into the cancer is kind of fixed because cancer is all kind of pretty darn similar, and so that may also be impacting the outcomes. It's not that the treatment doesn't work, it's that the toxicity is different, and we do see in the under 35s, it looks like they have more toxicity.
And I have a question. Can you walk us through how, when a young patient comes to Dana-Farber, 30-year-old, what is it you're doing different for that patient compared to a 70-year-old with colorectal?
Yeah.
What resources, what is the team comprises of for this age group?
So we have a trial underway where every patient under the age 50 who's diagnosed with colorectal cancer has stool, microbiome, DNA, RNA, protein, serum, blood, everything collected that we can, assuming if they consent. That's number one. And that's an important effort, and we're trying to get enough data out of that population to do things. We're collecting that in older adults as well, and we have to compare them. So that's number one on the research side. On the clinical side, we have a subset of faculty who are committed to the young onset population as opposed to the average onset population, so that we can kind of all work together and share experiences and share tips, really, especially for the very young patients like the teenagers. We have a subset of social workers assigned to the young onset population, and actually to this point, we have social workers who only see young onset patients because we have so many of them. We have nurse navigators who play that role as well. So it's a navigation effort. And the final thing is actually working with our colleagues in fertility medicine. So this has been a really, really interesting challenge in rectal cancer, where pelvic radiation is universally sterilizing, and where the use of irinotecan is on the rise in rectal cancer, which is universally sterilizing. So we now have a relationship with our fertility colleagues that young onset patients get expedited referral for fertility preservation. And so the social work is critically important for family resources, financial resources. Fertility preservation is critically important for, frankly, child rearing. And having kind of all the same people working together does make a difference in sharing ideas and sharing experience. And frankly, as a doctor, it's hard to take care of like a 20-year-old or an 18-year-old. And we're used to taking care of geriatric patients, and so that's a shared effort on our end.
First of all, thanks for coming to the Bladder Cancer meeting.
Yeah.
So have you done any exploratory germline testing and looking for either polygenic risk score or looking for things other than Lynch? And this is something that I've thought about in our young patients who have cancer.
Yeah, it's exactly what we're doing with the data collection. We don't have anything yet, but yes, we're collecting germline and tissue DNA on every patient who consents.
What type of exploratory analyses are you doing? Targeted.
So I would say right now we have an in-house NGS assay that we're doing, and we also now have DNA and RNA profiling underway, and we're trying to do single-cell seq in biopsies for these patients. It's a little hard, and we're collecting microbiome serially in all of the patients.
What's thought to be the association between like sweetened drinks and energy drinks and colorectal cancer?
I bet you it's a sugar effect. So this is a guess.
I read something about taurine recently and like Celsius and something like Red Bull.
Yeah, I think what you're actually seeing is if you take in enough calories, you can't metabolize all of them, and they're going to end up in the distal gut in a way that more conventional sugars didn't. And that's going to do a couple things. Number one, it's likely to result in bacterial overgrowth, and that may mean you have more oxidation of substances from non-oncogenic to oncogenic, carcinogens become carcinogens because of metabolism. It's probably that. I think it's less likely to be that there's some substance that universally in sweetened beverages. I think it's more likely to be bacterial effect. It's possible that sugar is the agent, but I think it's more likely that bacterial overgrowth is the agent.
Did consumption of sugary beverages correlate with TV watching?
This is just out of curiosity, and you may have already looked at this. So the rates of autoimmunity are also rising.
Yeah.
So have you seen any links? Because this is also mucosal cancer and allergies and autoimmunity.
Yeah, that's a fascinating question. So my research world, my clinical research world is in immune effector cell therapies and next-generation checkpoint inhibitors. So yes, we're thinking a lot about this. I would say so far probably not. I think those are mutually exclusive issues. It's still rare. It's just that it's not as rare as it once was. We're not finding different immune toxicity profiles in the young onset patients, such as they are, and our recent data of botensilimab with balstilimab, which I think is going to be very relevant in the G population shortly, is that we don't probably see a major difference in immune-related adverse events in that population. An indirect way of not answering your question, but so I don't think so yet, is what I would say. And I think it's probably a mutually exclusive issue.
And anything with contraceptive use in younger females?
Yeah, we have not looked at it yet.
I think this is really exciting, learning so much. This is our first session for young onset bladder cancer. I think we'll have to get more and more insights and do more of these sessions. But thank you for guiding us with your experience.
Thanks for having me.
Okay, our next speaker is Jeffrey Dummerer from the University of North Carolina, and Jeffrey is going to be talking to us about the genomic profile of young onset bladder cancer patients, as far as that is that we know currently. It'd be interesting to see how you define young onset and bladder.
So that is our, okay. So thank you for having me. In some ways, following up that is both, exciting that we have a lot to explore and depressing that other cancers are so much kind of further ahead than bladder cancer in this area. And so this is kind of pun intended. We really don't have any data yet for young onset bladder cancer. It's exceedingly rare, and there lacks kind of a universal definition of what it really is. And so when I started kind of looking into, so my background in general is genomics and transcriptomics of bladder cancer. And so when I started looking at the question of young onset bladder cancer, there were just a lot of questions that really started off, and we can kind of have a discussion as we go along if we want. But the first was, what even is the cutoff for young onset bladder cancer? What do we mean when we say bladder cancer, much like excluding certain clinical subtypes or histologic subtypes in colorectal? Do we include everything? Do we just restrict it to urothelial carcinoma? And then within bladder cancer, there's this very intertwined association between genomic alteration and stage. And so how do we kind of deconvolute that to really get at what are the differences in young onset versus just patients being diagnosed with a certain stage? So just very quickly, I think most of us know this and has been touched on, that smoking as well as other occupational carcinogens are really known to be causal for bladder cancer. Now, the exact reason for this is still not really well understood, but it's the accumulation of these alterations due to exposures as well as other potentially germline effects that lead to bladder cancer, and specifically amongst at a later age, because you're accumulating this DNA damage. So with young onset bladder cancer, it's probably not necessarily the same, if it is an exposure component, not the same exposure component is for the more traditional onset. But just as you see incidences rise as patients get older, we see that the proportion of muscle invasive disease also increases. So kind of counter to what was just talked about with colorectal, generally younger patients are diagnosed with lower stage, lower grade bladder cancers, which tend to have a better prognosis. So you can see that really the rates of muscle invasive disease are only about 7% of under 45, but within SEER, so about 300,000 cases, it was like 131 cases were muscle invasive. So we're talking about a really low absolute number. So before we, as this suggests, what do we even define as young onset when we look at these numbers? Is it a categorical? Do we want to think of it just more as like a continuous variable? And so it really depends on what the question is that we're asking. So if we're looking at it from purely a genomic situation of trying to characterize these sets of tumors, is it biologic differences? Or do we want to focus on where's the divergence in clinical and prognostic settings? So really, previous studies are all over the board as to what the age range should be. And when I say all over the board, I looked in PubMed and there were like 6 studies which particularly focused on young onset to begin with. So there's not that many out there. Actually, only one of them, the first one listed, was even an NGS study. The rest of them tended to be focused around either pathology or IHC. But you can see that 3 out of the 5 are sub 45, sub 40-year-olds, and then the 2 others are less than 19 or less than 20. So we're really restricting the ages because if you remember from that diagram of SEER incidences, it's really a small subset. So acquiring enough patients also might want to play a role in how we're going to accumulate samples. But again, how do we diagnose this? If we go by societal norms, do we say adulthood is, we'll go under 18 physiologically? So like, is puberty, age of cutoff, hormones, how does that influence the age of, young age of onset? Do we stick to a disease base? So you can see at about 40 to 44, the rate of diagnosis has an uptick. So does that denote that that's really when any of these exposures are setting in to increase your incidences? Statistical, we see that under 55, it composes about 8% of the cancer diagnoses in bladder cancer. So is that a good mark so that we can get enough samples? And the NCI defines AYA is below 40. So here we have all these different issues. Oh, and so here too, was actually very interesting when I plotted this, is I looked at TAT1 and then MIBC and just bin them by age. And really, it's under 60 that start to have a difference in outcome in a stage mapped setting. So again, depending on what we want to look at is how we need to bin them. And there's no universal classification. So it's really hard to kind of start looking at a problem when you don't even really know what the question or what the groups are. So next is, what do we mean when we say bladder cancer? As with colorectal cancer, there's various subtypes. They exclude some of those when he was talking about their research. So bladder cancer is extremely heterogeneous. Urothelial carcinoma is more than 90% of all the tumors that are diagnosed, but there's a number of histologic subtypes, divergent differentiation, but mainly across all of our age groups, urothelial carcinoma is greater than 90-95% of all the diagnoses. When we look within those that are not urothelial carcinoma, so squamous composes a majority, and that's pretty consistent across the age groups. But when we look at the other histologic variants, we see that things like rhabdo, myelio, mucinous, paraganglioma, these are at a higher rate within the extremely young group, and these are also tied to a lot of the germline syndromes. So for leiomyo with RB1 loss, that was shown to be at an increased frequency in those who survived ocular retinoblastoma. And so we really have to look at, are we looking for all cancer types, or are we focusing on urothelial? So looking at really the cancer of the bladder versus these other cancers that just one of the sites they could appear is within the bladder. There has been some work on germline risk factors already. So Maria Carlo had this very nice study in which they found that within germline mutations, about 5% were the MSH or BRCA1 and 2, so 5% of bladder cancers. So again, kind of with tying into what are we calling it, so this is, these MSH2 with Lynch syndrome, do we want to include that in our analysis? So we know that it's a younger age of diagnosis. It's upper tract, so it's not kind of the conventional bladder malignancy. So is this one of the exclusions, or do we include this in possibly understanding the underlying genomics? And then second, as with BRCA, it's one potential alteration that can contribute, but there are ongoing GWAS studies, kind of to get to the point that was made earlier, to look at polygenic risk scores, to look at, it's probably a multi SNP score that might kind of allow us to understand age of onset a little better. But I think, there's definitely way more to learn. And, I'm working on one of these GWAS with some collaborators, and part of the problem is just access to data as well. So a lot of data sets, because of privacy reasons, you can't get down to patient level, especially for the germline. So we may have a polygenic risk score, but we don't have what age these patients were diagnosed at, or we don't have exposure histories. We can just get the summary statistics. So there's a lot, I think, within data availability and data sharing that could help further these things that right now are kind of bottlenecking efforts. So finally, we need to resolve the stage and genetic interaction. And so as most people in this room probably know, within the divisions of non-muscle invasive and muscle invasive disease, there are really defined alterations which kind of segregate with these. So non-muscle invasive tumors tend to have higher incidence of FGFR3 mutations, PIK3CA, KDM6A, STAT2. They tend to be more genomically stable, have a lower TMB, and relatively they have a lower degree of immune infiltration, whereas the muscle invasive disease really is characterized by P53 loss, ARID1A, RB1, tends to be more genomically unstable, and also have kind of this more dynamic TME. And so because early onset tumors tend to be diagnosed at a lower stage and grade, they are kind of off the bat biased to have more of these FGFR3 and other non-muscle invasive alterations. So we really need to, statistically, when we approach this, understand through adjusting for those confounding factors to make sure that the differences we're seeing are not just a fact that these are all low grade, low stage, or conversely, is there a reason they're getting low stage, low grade, and is there a reason they're more kind of predisposed to these alterations? So I just took a quick kind of look through the data that was already available. So there was, as I said, there was one NGS study, next-gen sequencing study that was out there, although it was only 21 cases that had whole exome sequencing, and there were no kind of control cohort to go along with it, and it was all Asian ancestry. So there's really not a lot that I could glean from that. As a plug for CBio Portal, for anyone who's not genomically savvy, it's a really great website that basically houses a ton of genomic data that's been published. It has a really easy user interface, so if people just want to kind of explore and bin by different clinical variables, it's a great user interface. But I went into CBio Portal and I pulled out the MSK impact data that has previously been published. So the first is a non-muscle invasive cohort from Eugene Pietzak, and the second one is kind of their overall summary data on genomic heterogeneity within bladder cancer that had over, I think, 1,000 patients. And so I looked into there, and these actually had ages. So of all of the data sets in there, very few had age at diagnosis. There were some that had age at sequencing or other factors. But again, this lack of data and kind of universality of reported clinical features really hinders any of this retrospective analysis. And so in Eugene's paper, looking at NMIBC, we can see that if we split it into this below 60, above 60 group, that really FGFR3 mutations are dramatically enriched within that young onset bladder cancer, which is interesting because, again, this is restricted to non-muscle invasive disease. So there is some reason why those patients are having those alterations. Also, increases in STAG2 alterations, which STAG2 alterations are a known prognostic biomarker actually for better outcome. So it's interesting that, again, that younger population has these more commonly associated low-stage non-muscle invasive alterations that also confer or are associated with better prognosis. If we look at the MSK impact data, those kind of that more expansive set of data, and I actually spoke to Eugene about this earlier because I was curious, because we don't see the same bias with FGFR3 here. And he was saying that he was unsure, so this is all stage 1 samples, but how stage 1 was actually defined within that paper. So he said that stage 1 could be referring to those like T0, TA, T1, but low-grade samples, which would then further kind of increase that proportion of FGFR3 mutations. So again, we really have to be careful of what data we're looking at. But interestingly, STAG2, as in the other data, was increased within this young onset group of patients. When we look at the muscle invasive, so stage 2 plus in that data set, here we see the FGFR3 alterations increase in that very young population. However, ARID1A, which is known to be associated with muscle invasive disease, is consistent across all groups. And so this falls in line with some of the models which have been proposed before in terms of primary versus secondary muscle invasive bladder cancer, in which these young patients may initially start off with a low-grade, non-muscle invasive tumor that, for various reasons that kind of were hit on earlier about not being diagnosed right away and having to go back multiple times and advocate and kind of say there is something there, is allowed to then progress, acquire additional alterations, and ultimately develop into a secondary muscle invasive tumor, whereas the older population are getting diagnosed with that de novo muscle invasive disease with those canonical P53 ARID1A mutations. And so just kind of in conclusion, this really leads to kind of more questions and issues that need to be addressed than, these are the genomics of this population and that population. But really moving forward, if we want to tackle this problem and understand what's going on, we have to define what is the field going to consider young onset disease. And that could be different ages or different, is it this age if you don't have any risk factors, but depending on the problem. We lack a gold standard data set. So this is all things that were derived from panel sequencing, studies that were already published. But much like TCGA or UC Genome did for metastatic disease, we need a data set that can be collected, run together on a common set of platforms to really understand what's going on. And now with the power to do single cell and long read sequencing, ctDNA, it opens up a lot of other avenues to understand kind of the full picture. And then also, how does this factor into clinical trials? So if we know that young population is increased for FGFR3 mutations, but erdafitinib right now is only approved for metastatic disease, should we try to get these cohorts enriched for younger populations? Ashish was saying that a lot of the cutoffs is 18. So that may not impact it, but are we recruiting those under 40 or 50 at the same rate or to try to kind of bias it to that end to try to get more data. Also, so that's kind of the roles for targeted therapy. Immunotherapy, we know that the low-grade, low-stage are more genomically stable, less immunofiltration, so do these immune checkpoint therapies, are they just as effective? And then also, long-term screening, can we use urine DNA or cell-free DNA for these long-term follow-up for early diagnosed cases so they don't have to come in for repeat cystoscopies? Are they more likely to adhere if it's a once-a-year blood test as opposed to having to see the urologist to get scoped, every year? So how does that affect kind of compliance and adherence for long-term screening? And so with that, I just leave. So this is, I think it was actually commented earlier in one of them about the quote, "I'm trying to find precision medicine," and then, is the comment, just because we have a therapy, if it's being directed the wrong way, it really doesn't accomplish anything. So we really need to learn what's going on to kind of address this issue.
Great talk. I think we all agree within the clinical medicine that we're starting to see more and more patients, younger diagnosis. And clearly, genetics in terms of familial diseases haven't really changed. They should really be the same, right? So what exactly is changing? And I'm just popping from might be a little bit influenced by the pollution talk next door, but we're not changing our genetics families. Why are patients being diagnosed earlier? Is there a component of exposure that is causing these patients to present earlier with FGFR mutations and not really have anything to do with just spontaneous? Right?
Oh, yeah, I think that's a great point. And it kind of goes to this effort to, being on the research side of it, I don't design these big, trials and whatever, but being able to increase the diversity, not only racially or ancestrally, but geographically, urban versus rural. So increase overall just the diversity in patients that we can collect samples from, and to understand, is it the environmental context? So going back even, every now and then I'll go through and look on PubMed and see what's the earliest reference to bladder cancer I can find in PubMed. And there was an occupational exposure paper from 1930 that had looked at bladder cancer related deaths. And they found that if you work out in a farm where it's open air, you're at a lower likelihood to die from bladder cancer than the people who worked in the coal mines or in the textile mills. And so there is something with environment, with exposure, that could be playing in. There was recently a paper in Nature which looked at the gut microbiome and BBN-induced tumors within mice. And they found that the microbiome tied into how the carcinogen was being metabolized. And so that they attribute to the effects of BBN. And so there very much could be something with the gut microbiome and exposure with the younger populations now that's leading to this. But again, these kind of comprehensive pictures need to be collected.
Hey, how's it going? My name's Tim Clinton. Thanks for highlighting that paper.
Yeah.
It's, I think it's a really great sort of resource when looking at the genomic alterations underlying, somatically a lot of these tumors. To actually go to this question really quick, and then I'll make a comment. If you look at bladder cancer versus lung cancer and carcinogenic exposure, the onset of bladder cancer is much more delayed than, say, lung cancer. And so I think it's actually the long-term, even a brief exposure to, say, tobacco or something along those lines. So I think these younger onset bladder tumors are actually being driven more genomically than by the environmental factors that you see in sort of older onset bladder cancers. And that's where that ARID1A comes into play. I really think that that's a main driver in these more aggressive type tumors, and why you see it a little bit more in that in our series versus Eugene's original series, in that these are more high grade, more aggressive type tumors. And so that's where that ARID1A model kind of comes in, and I think Corey Botchen's lab has done a nice job of demonstrating that.
If you look at to the uromal cohort, in any of these non-muscle invasive, ARID1A and a lot of chromatin modifiers really are not nearly as highly mutated as in TCGA. And I remember when I had worked on the 2014 TCGA paper, and when that came up, there was all these chromatin modifiers. It was really kind of revelatory, yet we still kind of are working on how to best kind of exploit that, but yeah.
And then we've done, it's actually so timely that you guys have put this session together, so it's fantastic. We have an abstract being presented at New England AUA by one of my research residents, Chris Magnani. But we've looked at now at the Dana-Farber and Brigham cohort, which is 134 patients. We struggled with what to set our cutoff at, so we went with 55 years old just because it gave us more tissue. But this is totally arbitrary. and we've done next-gen sequencing on those patients. And we've seen similar trends. I mean, I don't know that it's too different, but it was still a lot of those chromatin modifiers, again, ARID1A, KMT2D, that were a lot more predominant in these younger patients. Anyway, so we've made some conjecture about it. But so anyway, we've done a first foray. Maybe there'll be another paper here shortly, at least looking into it and looking to explore more.
Yeah, I think you're right on the money because Niyati Lobo, who was a Fulbright scholar, spent some time with me at Anderson. And I think, Akshay, when you were there as well, used Lars's Uromol cohort and saw almost exactly the same thing. And that should be out pretty soon. The other thing clinically, at least, and again, it makes sense what you guys are talking about, right? Because we used to be, and even now, patients under 40 tend to have the lower grade non-muscle invasive disease, but the patients I'm seeing under 20 tend to have the invasive high grade disease, right? So it's like clearly not a simple answer, and it might just be a genetic and an exposure, both acting at different stages.
Has anyone used the like any real world evidence databases like Flatiron or the Garden database to get more accurate representation of treatments versus molecular versus diagnosis dates, etc.? Recognizing that those are smaller targeted panels for commercial testing, but could that help elucidate some of these different patterns?
It could. I think as more, so the problem with that is next gen sequencing, and a lot of the sequencing platforms don't have the low grade tumors. Because how frequently is someone taking a low grade TA out and sending it out for sequencing? And so that's part of the problem, is kind of you have to go in knowing what you want to collect and kind of go out and get it.
Do we want to make a comment to that? But Dr. Kamat's comment earlier that we actually, in addition to the look at 300 data sets, we did look at foundational medicine. It was all in muscle invasive bladder cancer, but we looked at the Swedish database, we looked at the foundational medicine and the TCG, and actually we found that the older patients, they had better biology. So kind of goes along with what you said. We didn't really describe it as early onset and very young patients, but it was 60, 62, 75, and 75 and above. But we clearly saw that the older the patients, they actually had, the younger patients had worse biology. Older patients had favorable biology, but we know that in real world, older patients do worse because of access to care. So we did like this combined study, which we're trying to hopefully get published soon.
So, one of the things we would like to do from this breakout session is actually make this a working group, because it's a small, manageable enough group. And one of the easy things to do is exactly what you said, like we need some definitions, otherwise we'll be spinning our wheels. Could we start that right now? Like show of hands, what do people want to consider young onset bladder cancer? Less than 40?
Should be 2 standard deviations.
That's what I was going to suggest.
Yeah.
Like
That's what- that's
one or two
it.
standard deviations below the mean age of diagnosis.
So what age do you want to pick?
Yeah, I don't know. I'm not good at this.
70, yeah.
Yeah, pick a number. Don't throw these things out. I'm going to call on you. So what do you want to? What?
44.
44? Okay. Anyone 43?
When the immune decline, because it
Yeah, as I
also
say,
coincides with the immune decline and BCG is.
Yeah, and I think like
early stage, right? So
around
you
that
have
52,
intersect.
you're also getting, I guess, if you do it with the caveat that you get enough, if you're really looking at it and you're looking at enough patients, if you can subset out. So like if you set it at 50, you can always do a subset analysis on under 40. But if you started under 40 and you're missing that 5% of patients, then you may never get powered.
If you go back to
No,
Yeah, I was gonna say, but you have to be careful also with, so we've been struggling with this tremendously. What's our definition? You have to not just, at least within colorectal cancer, not just define your age. Is it 35? Is it 50? But I think a birth year cohort assessment is really, really important, because if we're saying it's changing over time and you have archival data from 25 years ago, the exposure hasn't happened yet. And the data that you have now, the exposure has happened yet. So you have to think about your definition, which is impossibly hard, but you have to be really careful with archival data, because what we're going to do is we're going to start pulling out samples, right, from pathology, and then we're going to start analyzing them, looking at age and not at date, year of birth.
You're saying because environmental exposure.
Environmental exposures are going to change over time.
Over
So what
time.
you need is your definition. We're going to take the bladder cancers under 50. We should look at them now and look at archival specimens 25 years ago. And a critical thing is to see the change over time, because if this is real, which we all think it is, and it's not genetic, right? This is not a heritable problem, it's an exposure problem. We should be able to see a difference over time.
And to get to that, I was just thinking as we were talking about kind of the exposure and young age, but you know, if it is something in which, who knows, maybe maternal exposure, and then, or you know, so there's a lot of other, like, you know, exposures may have changed in the maternal population of these people with young onset. So it gets a lot more complicated when you're trying to deconvolute kind of the epidemiology.
Yeah, same with
Exposure
microbiome.
rates have risen. So
Yeah.
there's a national annual youth tobacco survey that's sent out by the FDA. It's been collecting data for at least the last 10 plus years. What it clearly shows is in 2015, 25% of high schoolers were using tobacco products and about 10% of middle schoolers. Now, the high schoolers have actually dropped. The last iteration in, I think 23 was the high schoolers were at about 13%, middle schoolers were up to still about 10%. So, and middle schoolers actually gone up. So the birth year mark absolutely makes an impact on this, because even though there's a latency instead to getting bladder cancer, the earlier you start your tobacco exposure, you're more likely still to get your cancers in your 40s and 50s.
Maybe I missed it in your SEER data.
Yeah.
Did you see a change in incidence in that young age group over, from 1970 to now or whatever, over years?
Yeah, I don't believe.
Yeah, that's our birth year cohort. Starting in 1970, the birth year cohort changes, not the age. But if you're born from 1979, yeah. And the microbiome is confounded too, because people come in with an upset tummy or with dysuria or hematuria, and they get hit with antibiotics as like a generic effect. Everyone gets their Z-Pak or whatever, the superflagyl. And then we go and they get diagnosed some months later, and we do a microbiome assessment. And we've actually missed our window of opportunity in assessment, because what we've done is like wipe the slate clean and just have this regrowth population. That's actually not probably the microbiome of the exposure. That's the post-antibiotic, because what else am I going to do, exposure microbiome. And so it's also really challenging to interpret.
In terms of exposure, the only other thing I point out is in lung cancer, for example, the paradigm was that if you had 20 pack years, your risk of getting lung cancer was very high. Once you quit and you put it down, your rate was, once you quit 10 years, your rate of getting lung cancer is down 1.5 times of what it would have been from the whole population. We don't have any such statistical parameters in terms of bladder cancer. Just looking epidemiologically, which is a simple way to look at it in terms of exposure. But certainly, given age of onset being sooner in terms of exposure to tobacco products, it's one of those things to consider beyond genomic things.
So if I can, you opened up the can of microbiome there, but
That sounds dirty.
If I can say, like, for example, there was a study published on, I think some of you have seen, about the health of horses, not humans. The health of horse and their microbiome actually predicts their ability to win races and be really healthy. Association, get it. But however, their microbiome is not just their microbiome. Their microbiome is a state of the health of the actual horse, right? Now, if we extrapolate this to humans, our microbiome, similar with the cohort and similar with exposure, similar to what we're eating maternal, is changing. And not necessarily the microbiome itself, but the microbiome maturity and how it prompts your immune system to respond, because we form cancer cells from the very birth, right? To response to cancer cells also probably has some sort of correlation to why we're getting these new tumors early on.
That's why I think really, look, I don't think it's everything, but I think potentially there's something there with like looking at the GWAS and polygenic risk scores, because that, you know, can tie into all the aspects of kind of immune regulation and DNA repair, and there's a lot of things that, you know, when we take that larger view, I don't think it's going to be yes or no, but it could say, be something where if you do have the exposure and you have a polygenic risk score of whatever, because you have SNPs that are affecting the immune system's ability to clear whatever, you know, damaged cells, that it's going to be something that's really, you know, a lot more complex.
I think you had a question.
I did, so I've been contemplating and asking it. If the younger onset is more than indolent disease, how long do patients ignore the symptoms before they actually present?
This might be a great four-way for me too.
Yeah,
So,
so-
I mean, could a 39-year-old that's been dealing with symptoms
Yeah.
for 10 years?
Video.
So we'll now switch gears to our actual patient stories. We have a video from our patient, Kristen Watts, which will play now, and then we have Brent here, who I'm sure all of you who were here yesterday listened to his amazing story. So, and then we'll come up with some questions we had sent ahead of the session around fertility and reproduction and other issues.
Thank you so much for taking the time and spending. It's the diagnosis of cancer, especially bladder cancer, in young patients, right? And it's really inspiring to hear your story. And I really want to thank you right up front for taking the time and spending with us today.
Of course.
Could you share with us a little bit about what was going on in your life when you had these symptoms and suspicion, and what led to the diagnosis?
Yeah, so I was currently in nursing school. I was having a lot of burning with urination, but no infections, no blood in my...
Thank you so much for taking the time and spending. It's the diagnosis of cancer, especially bladder cancer, in young patients, right? And it's really inspiring to hear your story. And I really want to thank you right up front for taking the time and spending with us today.
Of course.
Could you share with us a little bit about what was going on in your life when you had these symptoms and suspicion, and what led to the diagnosis?
Yeah, so I was currently in nursing school. I was having a lot of burning with urination, but no infections, no blood in my urine. And I had a lot of swelling in my lower abdomen. It started to look like I was around 4 months pregnant. And I was very lethargic, very pale. I was anemic. My blood count was low. My hemoglobin was low. And that was pretty much my symptoms. And I tried to talk to many doctors about it, but they just said I was hormonal or going into womanhood, and that these things were normal.
Yeah, you know, again, hearing that your symptoms were dismissed is really disheartening to me personally. How did it make you feel at that time?
I was extremely frustrated. I went to many different doctors. I saw many different specialists, and I just kept telling them that something was definitely wrong. And they just kept telling me I was fine, I was just emotional, I was just in nursing school. You know, nursing school can cause people to either lose weight or gain weight, so I was just gaining weight. So that was just what they told me.
Yeah, it sounds like you had to persist and persevere and advocate for yourself, which I think is very, very important, right? In retrospect, what are some of the pieces of advice you would give other young adults that are facing a similar situation and trying to get their doctors, in this case, primary care physicians, to take them seriously with their symptoms?
I would just say just keep persisting. I kept going back and back and back again with the same symptoms, and I just wasn't letting up on, I said I wanted a CT, I wanted an ultrasound, I wanted to see a specialist, and that something was wrong, and that if they didn't start taking me seriously, I would find someone who would.
Yeah, now again, kudos to you for sticking to your guns and persevering. We often see in young patients and in women of all ages that the diagnosis of bladder cancer gets delayed for various reasons. And again, we're not here to point fingers, but a lot of times it's just lack of awareness. It's lack of awareness on the part of the primary care physicians. It's lack of awareness on the part of the patients and their carers, who sometimes will ignore their own symptoms, right? So it's really, really good that you got that diagnosed. Now, with the diagnosis and the counseling that occurs, one of the things that we found our patients and their carers often share with us is that, especially in women, there is not much of a discussion of the ramifications of the procedures and the treatments on fertility and sexual function. And I know it's a sensitive topic, but would you mind sharing some of your insights and how your journey through those sensitive topics was addressed?
Yeah, so of course, being a female, the way the cystoscopy is done is the same as a male, but because of the urethra being shorter and many things, you are a lot more prone to infection, bleeding, scarring of the urethra. And because of all the urethra, it being so close to your other sexual organs, when trying to be intimate or do anything, it can cause lots of pain, dryness, irritation, and many different things. And then of course with the bladder cancer, you get treatment done most of the time and you have surgeries done. And a lot of times they say they don't think that you can have kids at that point. Now, mine still came, but they did say that they didn't think I would be able to have kids, and then I was able to.
So was this discussed with you, the implications of your treatment on sexual function and fertility?
No.
Yeah, so I think that's one of the other messages that we want to put forward, is that this is clearly something that needs to be at the forefront of, on our part obviously, but also patients should be asking that question, and I think your message kind of highlights that. And congratulations, by the way.
Thank you.
When's the big due date? It's right around the
August
think
11th.
tank meeting, right? Great.
Yep.
Now we hope to see pictures and of you holding your
Of
baby.
course.
That'll be great. So Kristen, obviously, I don't want to take too much of your time, but sort of at a high level, if I were to ask you, if you were to speak to patients, and let's focus on the young patient, male or female, what would be some of the messages and pieces of advice you would want to give them about how to go about advocating for themselves and navigating this journey?
So I would say a big thing is making sure you have a good support system as well. At the time it was my fiance, but we've since got married. So now my husband, he's been a great advocate for me as well. If there was times where I felt as if I couldn't go forward, he was there right behind me to say like, okay, wait, I know what she wants and she wants this to be figured out. And then my mother, she is an RN herself. That was very handy, as she'd be like, I'm a nurse, I know what's going on as well, and something's not right. So if I wasn't in the right state of mind to continue pushing or advocating for myself, I had two other people in my corner who knew that that something was wrong and that I needed help.
Great. So advocate for yourself, lean on your friends and family, and create a support group for yourself, just to get the right answers and get to the right people. And Kristen, now obviously you're in nursing school and you're a healthcare professional. So if you had to switch gears and now give advice to your colleagues and peers, the physicians and nurses that might be seeing patients that they're not used to seeing, young patients that might have a suspicion for cancer, what would some of the pieces of advice that you would give to your peers be?
So my advice would be that you can have any illness at any time, at any age. I know they always say that bladder cancer is in 80-year-old men, which that is just not the case anymore. It's being seen in women younger than I am, a lot worse stages than I was, as it's being put off as a gynecological thing when it's not always that simple. And I would say just to take your patients seriously. I know it's hard because you see so many patients, and some patients can be a little dramatic. I've had my fair share of dramatic patients, but when someone says there's something wrong, it doesn't hurt to listen.
great points. And in closing, I want to congratulate you for sticking to yourself, for getting through it. I understand you're in remission after undergoing immunotherapy with BCG, and now you have a young, precious bundle of joy coming your way in a few weeks. So congratulations on everything, and thank you so much for taking the time.
Thank you.
We have an update from Kristen. We have a picture of her baby, so that's.
Brent, why don't you go ahead
And now we listen to Brent, who has a great story to share.
Yeah, thank you all very much, Dr. Gupta and Dr. Chazom. Hope I said it right. I always call you Stephanie, but thank you guys for having me here. This has been fantastic, by the way. I'm extremely grateful for everybody in this room. I'm learning a lot, and makes me want to go back to school. Like, I know you'll probably all tell me, don't go to grad school. My wife said it, but I'm like, this is just really fun. I love to learn. So hopefully you all saw me talk last night. I don't want to rehash a ton of stuff, but I've been taking notes on some things that I've forgotten. First, my mother always told me I was special, and after looking at some of that data set, I did not realize how unique. 0.26% for the 30 to 34-year-olds. I'm born in 1987, diagnosed right around my 33rd birthday. So one of 131, I think. It was T3 muscle invasive UC. And to answer the question in the back, I don't know the exact date. I could probably dig it up, but it was about 18 months, maybe 2 years of symptoms, just like Kristen's. So 0 blood in the urine, because that would have made me really sound the alarm. But episodic painful urination that was getting longer in duration and longer in frequency. So it'd be like, oh, I may have ignored the first 1 or 2 of just being like, that was weird, that was burning pee, but it just, you couldn't ignore it towards the end. A couple other things too that I just thought was interesting. So last night I was speaking about some of the drugs that I stopped taking during chemo. So I did MVAC. The first time when I did the MVAC, where I was bald, I just did everything that they told me to. But then the second time, so that was in the summer of 2020, then I did Cisgem, which eventually changed to carboplatin, and by the end of it I had been cancer-free since the onset of my chemotherapy, so this was all snuffing it out. So I was starting to play with more, what could I do or what could I avoid, and I stopped taking the Dex and the Zofran, and I felt so much better after I stopped taking both of those. They were the side effects from the drugs to help me made things even worse, so I pretty much just did my chemo, and then I would just have this box of pills that I never took, and it made me feel a lot better. Another thing that was really, really strange is I've always gotten canker sores, but when I was on Bavencio Vilumab, I did not get any canker sores. They have returned a little bit. I know this is a bladder cancer conference, nobody's doing research on canker sores, but somebody should, because they're really freaking annoying. They've come back, but not nearly as much frequency. Do you want me to line out my whole story, or do you want to go to questions?
Some of the challenges that you faced, as did they discuss the different kinds of bladder surgeries with you, what your lifestyle would be, and
Yeah, I mean, I met with several different urologists and surgeons, probably 3. They all, and my oncologist, all told me you have to get your bladder your bladder has to come out. And that was like the biggest thing on my mind is, can I just keep it? I'm pretty young, and they're like, no, it's got to come out. It's the best overall survival. So that's what I did. Dr. Chandra Wilson was the one that really enlightened me to the fact that I could keep my prostate. I wasn't really thinking about that. People weren't bringing up sexual activity and health. Obviously, we were pregnant with Van. I had my cystectomy 3 months before he was born. So I guess I just wasn't thinking about what our sex life was going to look like in the future, but it wasn't really brought up very much. So I'm glad I kept my prostate. What else?
Did anyone else also talk to you about sperm banking? Any challenges?
Yes, I did do sperm banking. Nobody told me that. So now, like, ejaculation is non-existent pretty much, or it's come back sometimes. It's very, very odd. But other than that, my life is pretty much back to normal. And then the catheterization, that was another thing that wasn't discussed, was and I'm actually going to join a group, Lydia's group, I think, and have some discussions with them. But as I talked about the other day, I went through about 18 months probably of just retaining a ton of urine and not realizing it. and getting infection after infection after infection and getting pretty depressed, thinking like, is this my life? Am I just going to be admitted to the ER every 6 months? And then my urologist was like, why don't you try cathing? I was like, okay. And it, you know, it was like that scene in Dumb and Dumber. It just kept coming. And I was like, oh my God, this is all the urine that's inside me all the time. So now I catheterize pretty regularly, and that's tedious, but I go through a lot of podcasts, and it's so much better than the alternative of just literally not being here. Like looking through these numbers and all the progress that's been made the last few decades, it's pretty incredible.
Yeah, I have a question for the urologic oncologist in the room, Ashish, including you. When you see the young patients, do you have a preference of neobladder versus conduit? Or, of course, it depends on the tumor location and everything, but because a lot of patients have developed a lot of body image issues, even our older patients.
Yeah, no, I mean, short answer, yes. In younger patients, we tend to want to recommend orthotopic diversions to them a lot more, even though oftentimes the patients will not want that, which is very surprising. For example, the 17-year-old that I had some time ago, it was a very rare tumor, and I can mention her name because she was on CBS Sports, but 17 at that time and needed her bladder out. Most people told her she's only have a year to live, so she won't really make it beyond a year. So when I was she was my daughter's age at that time, so I'm trying to convince her to have a neobladder, but she's like, no, if I'm going to live a year, I don't want a neobladder, right? So the reason she was on sports was even with the stoma in place, she got a soccer scholarship and played on the OU team, and then now she's at Harvard Law and doing all that stuff. But the thing is, we try to push patients a certain way, but she's the happiest 22-year-old with a stoma that I know right now, right? So yes, we do, but it's always important to hear, even from our younger patients, if that is actually what they want. That's my personal bias.
Yeah, I agree. I mean, you have to have just an open conversation about what reality is afterward and quality of life and implications. And I mean, I find younger patients want a neobladder, and can have an excellent quality of life. And it looks like you're going hiking and.
Yeah, we talked about all the different options I had, and I swim a lot too, so I was like, I've got a big scar. I asked my surgeon if she wanted to go the laparoscopic, robotic method. She's like, I do both, and everyone's like, go robotic. I'm like, what are you more comfortable with? And I had to ask her about 5 times. I'm like, come on, if I had to bet you where you're the best at it. So she did an open surgery, so I've got a bigger scar, but I don't care. Yeah, so it wasn't important to me. So.
Yeah, but I just wanted to follow up on your, we heard a lot about some patient advocates saying they had the neobladder, but they didn't have a lot of teaching, like what will life be after that, what's the rehab look like. Are there specific programs where you practice where those patients are following with physical therapy or some life rehab, occupational therapy?
I mean, so you're talking about, the reality of post-surgery having a catheter for 3 weeks, and then, starting to train the neobladder, and we have a protocol for that, and pelvic floor therapy if they're having urinary infusion, and the possibility of having a catheterized. I mean, I don't have all my patients catheterized, I don't know if you do, but I think those are all, you have to go through all of those sort of the realities of having to go through.
I mean, anyone who wants a new bladder has to tell me that they want a new bladder.
Yeah.
So that's sort of the rule of thumb. And the second thing is I have all my patients with neobladder catheterize themselves in front of me to make sure that they're comfortable and they understand. Because I think talking about catheterization is one thing, and then doing it is a very different thing.
Yeah.
So
I think that probably would have been helpful too. Like I literally, they just showed up in a box on my door, and I'm like,
Yeah,
okay,
exactly.
let's go figure this out. And
So
I
they
think
should do
Googling
right
it,
there.
yeah.
No,
Yeah.
I do. When they have a visit, obviously after, but when we have the discussion about neobladders, like if you want a neobladder, you give them a catheter and they catheterize it.
But I find when you have this discussion, particularly with older men, I don't and younger men.
But to that end, unfortunately, I have a number of my own patients who are under neobladder said, give my cell phone number to prospective patients and have them call me. I actually find that peer conversation is just as effective as the counseling. And I did the same thing as Laura. If they're going to get neoadjuvant chemo, we talk about diversion types, and I specifically say, do not decide today. You're going to have 3 months of chemo and recovery. Research it. Talk to these people. Read Beacon. I pronounced it right.
Yeah.
And then I always said a pre-op visit, usually like 2 weeks before surgery, as kind of a pre-fight checklist, and I make sure they're willing to catheterize. And then always the oncologic caveat. It's like, you know, if we can't achieve a negative urethral margin or other sort of absolute indications, you have to understand you may wake up with a different type of burden.
I think that's a great way to do it. What all the steps you just laid out.
And actually, where I trained at University of Kansas, we also had a stoma boot camp, which was really nice, which was peer-led. And one of my colleagues, Andrew Zaganderson at Mayo Jacksonville, has published on that work. And I actually think that might be a good, broader initiative as well. And it's sort of a group counseling session. I think they did it like 6 or 8 times a year on an evening weeknight with our urology nurse educator, stoma nurses, patients who 1, 2, 3 years out from cystectomy who had actually lived in the real world. So I tried to take some elements from all that and put it in the current workflow that I have.
Yeah, I think one thing we have to be a little cognizant about that is we end up selecting or cherry picking patients who've had the best outcomes, right?
Well,
they're the ones who want to talk to other patients.
I agree.
And oftentimes, I totally agree with what you're doing, but our best patients are trying to sell the other patients on what they have being the best thing is something that we have to be careful we
They never
don't
say,
do.
oh, I regret my decision.
Sure.
They're always like, this is the best one.
Yeah.
That's
Especially
we
to
hear
the
that.
surgeon.
Yeah.
That's what Facebook groups are for.
Sure.
There was, a couple questions.
Mike, yeah? Oh, sorry. Go ahead.
Hi, just wondering if you had the, because you said everything was offered to you. Has anyone talked about trimodal? And then the other following questions will be, what are your feeling in treating, I haven't treated that many young patients who go for cystectomy, but how confident will, as you know, your oncologist or radiation oncologist, if they're doing about trimodal for younger patient? And then you can balance with, I wonder what colorectal you have, because rectal cancer, you will often do multimodal, and you said they don't do as well with intensification. So that was my question before, which I didn't get to ask about how to do radiation.
I don't know what trimodal is.
Oh,
Maybe I don't.
Sorry.
Yeah.
So it's chemoradiation. So you receive some sort of chemotherapy to sensitize, but you get radiation of your bladder
Okay.
to preserve your bladder.
Different than BCG. It's like a.
Different, yes.
I don't think
So
that was discussed.
instead of bladder removal, you get radiation of the bladder.
Yeah, that's why. I think because it was so deep in there, and they
Okay.
removed a couple lymph nodes when they took it too.
That's a candidate for that, that's for sure.
Yeah, yeah.
I mean, in terms of the rectal cancer experience, there's a lot to unpack. It would take 3 hours. And I would happily talk for all 3 of them. So what we have discovered is that modern chemotherapy that's highly active with lower risk, locally advanced disease, that if there's a response to chemo, you can then avoid radiation. And so patients with low risk stage 3 and with stage 2 disease who have chemotherapy and have a substantial reduction in cancer can avoid radiation without any consequences. And as a consequence, they have better functional outcomes in terms of bowel function, sexual function. So that's point number 1, and 91% of patients can avoid radiation in that subset. For patients with lower down cancers, we know that intensification of therapy can result in organ preservation. So you start with radiation, followed by intensive chemotherapy, and 44% of patients actually have a complete response clinically. But in long-term follow-up, only 22%. So half the people with organ preservation don't have organ preservation. And one of the greatest letdowns for a patient is they get through their year of therapy and it's all gone, and they get a high 5, and then 18 months later, they're going in for an APR and a permanent ostomy. And it is devastating for patients to go from a clinical complete response to an APR with a permanent ostomy.
I think in the realm of trimodality, that's part of my counseling script to patients. I think you have to examine yourself if you're considering organ preservation and think about if at some time point down the road you have a local recurrence and we recommend cystectomy, like can you reconcile that? Are you going to be okay with that, or is that going to be enough of an emotional setback that you would rather just move forward with non-organ sparing surgery up front? I think that's really hard to tease out.
I'll just comment, being at Mass General,
Yeah.
having a fair amount of experience
Yeah.
we've shied away from trimodality in young patients. I mean, if a patient came and really wanted it and they were a candidate, it's about a third of patients with invasive bladder cancer who are a candidate for that. I think we would. But right, they need lifelong surveillance. The risk of a muscle invasive recurrence is probably about 15%, if I remember correctly. The risk of just any non-invasive recurrence about 25%. So they need lifelong surveillance, just like somebody who's young who had a high-grade T1, right? Would need that. So, and if they do need a cystectomy, we have not done neobladders. We've done conduits.
Can you talk about specific survivorship issues in the salvage, or the people who need salvage therapy? Like what
Yeah,
your
so
experience-
actually,
because you guys probably have the
yeah,
biggest
so
experience.
if you do a salvage, we've looked at that. We've looked at survival after salvage cystectomy for a new invasive, and actually the survival is comparable to those who have a de novo cystectomy.
Beyond oncology, though, I mean day-to-day patient-oriented survivorship concerns like maybe not being able to have a neobladder or
you mean
sexual dysfunction.
Their quality of life.
Correct.
Right,
Quality of life
so,
outcomes.
well, the only quality of life data for tramadol, we're getting a little off topic, but the only quality of life data we have with comparative is between us and UNC, actually, and there's quality questionnaire data. It shows that the sexual quality of life is better after tramadol than after cystectomy, which makes sense.
But Adam, I would push the back on that, right? Because I mean, again, we all have looked at this over decades. It's the older patients
That's older
that have,
patients.
right, that's older
Correct.
patients.
Yeah.
All comers, roughly 25-30% are candidates for TMT,
Yeah.
and then TMT is the gift that keeps on giving. So the younger you are, the more time you have for all the side effects from radiations to catch up with you.
That's exactly it.
So
And
how many in the room?
That's the thing I was also
How many in the room would
thinking about.
recommend radiation therapy for a patient under 40? How many?
Well, the same way if you treat an early onset prostate cancer, you're not really interested, if you have your 45 years old prostate cancer, I will shy away from radiation.
That's exactly it.
Yeah.
You have to have a very long time
Yeah.
to have those long-term consequences from radiation.
What is your
And that's why
cutoff for
physicians
shying away from trimodality? You said for your younger, is it 45, 40?
For age?
For age, do you have a cutoff?
I mean, I would say say even under 50 to 55.
Okay.
I mean, we haven't, yeah. Those are
You
young.
discuss it with the patient and then make your preferences. I
There was
think
one
Mike
question
had
at
a
the back.
question. Yeah, Mike.
Sort of more of a comment. It's interesting, for the younger patients, a lot of the people that have already presented talk about or showing pictures of having young kids, and I think that logistical aspect, going through care, but also finding child care or sort of getting treatment in sort of the prime working days of their life, rather than the 72-year-old that's retired and they have a little bit more free time. And a lot of times we don't sort of talk about the burden of care based on sort of age distributions for these patients, right? So like if I'm retired, it's much easier to come to and from appointments than it is if I need to find childcare for my 18-month-old, or what support networks those people look like. A lot of times, I mean, I had a 23-year-old that got diagnosed with CIS, and she was getting bladder treatments, and she was trying to figure out who's going to watch her 18-month-old while she was getting treatment in the infusion center because the kid wasn't allowed there. So it's a lot of those logistical things that we sort of, nuances that we don't really sort of think about or have not sort of really addressed in our younger patient populations also.
Yeah, that's a really great point, besides the financial implications.
Obviously, bladder cancer is more common in men than women. Has anyone looked at to see if it's the same is true for the younger population? Is there a gender discrepancy? And also for colorectal cancer, is there an incidence more in men versus women for the younger onset cancers?
At least when I looked initially at the SEER data, it did not seem like there was a large shift in sex based on.
It was unchanged.
There might be more of an even balance in the younger age, but that also could be due to kind of those germline other tumors that were included. So I'm not sure there wouldn't be enough that I would look at and say like, this is something we really need to.
But it's historically known to be more aggressive
Yeah.
in women,
Yeah.
especially younger women.
I see a lot of women just by being female. I think there's gravitation for female providers, and it's rarely do I see urothelial. It's always something very enlightened, sarcoma, sarcomatoid, like everything under the sun, squamous, right? So their disease outcomes are just so much worse.
Now, in young onset colorectal, you showed those sobering statistics about less than 50-year-old women.
Yeah.
So it's more aggressive in women too?
It's more, well, that's just where we have the data from because of the Nurses' Health Study. As far as I can tell, without giving you real data, I think that we're gender balanced. There's some older data that, some older trials where they looked at men versus women, and actually men had better outcomes in the older clinical trials with surgical outcomes and chemotherapy outcomes, but that may speak to other factors that contributed to how they were treated. And I'm not sure if that has been carried through in the modern era. But in the pre-TME era, women had inferior outcomes with increased local recurrence, which is now 30 years ago, 40 years ago. And there were some older data on fluoropyrimidine plus oxaliplatin where men did better. But again, those were older regimens. There's lots of contributing bias. So I hope it's the same in the modern era, but I don't know.
And I have one more question for our providers here. So are you going out of your way to provide psychosocial support to the patients, like setting them up with a psychologist or because patients have a lot of emotional needs, and we as busy oncologists and surgeons are really not capable of addressing those all the time. So I would love to hear what you all are doing.
So one comment regarding that. We I'm at University of Alabama in Birmingham. We have a dedicated AYA group, and I was going to ask you if you got hooked. Doesn't sound like you were introduced to this group or know what it is, but
No.
it's the young oncology group. And the definition is less than 40. It's supported by NCCN.
Yeah.
And back to our definition cohort, we'd be sure to, part of my ranked me like maybe less than 40 because we're going to include this group, and that's important to get that group's support for this sort of stuff. So anyway, but the point is the AYA groups have been instrumental in folks less than 40 and getting them to the psychosocial support that we've had and fertility preservation. And no one's mentioning women and fertility with cystectomy patients, which is a big deal in the few patients you get to do that. So I completely think that I would wonder if anyone else has had AYA groups that can provide that support.
What does AYA stand for?
It's like
Adolescent and young adult.
Adolescent and young
Adolescent and young
adult.
Okay,
So it's less than 40.
Yeah,
It's 40.
UNC has just in the past few years started up, and they're going to devote actually like their own like lounge and infusion, like an
Right.
area that's just for them, because they
Physical
found
space.
that really helps psychologically for them. I don't know as far as how many bladder cancer patients they're seeing in that, but just in general, that AYA, they have a devoted mental health counselor. They have,
Right.
it's really,
It's usually driven from the pediatric side.
yeah.
Right, so you don't know, I didn't know about the CQAB until I got involved with peds folks. And I was like, oh my gosh, what an awesome
this-
resource they
yeah.
will provide for people that are
Yeah.
over 18.
Yeah, UNC,
So-
I think it's independent of peds, but it's definitely kind of hand in glove with.
Right.
We're starting
Yeah,
something
we-
at the Cleveland Clinic, but for all cancers, like a
Yeah.
young onset.
Yeah, we've sort of struggled because these definitions, you end up with the 35, 40-year-olds who are worried about missing work and a young family, and like the 17-year-olds, and they are in a different life. And so the Jimmy Fund, which is a big funder with Dana-Farber and their clinic, we now have an adolescent young adult. I think it's 25 to 15 or something like that, or 20 to 15, and then the young onset adult populations, which we segregate purely because of volume.
And
Yes.
that one, Dr. Berg, who was here previously,
Yeah.
then jumped out. She and I worked quite a bit with the, I don't even know what we're calling it, young adults group at this point. We do a lot of testicular cancer care. And Home Goods has actually donated quite a bit for under 40 populations for the lounge and the same psychosocial support for oncofertility.
And where are you practicing?
Dana-Farber.
At Dana-Farber, okay.
But
Nice.
it's a collective group to make sure these appointments happen. 'Cause
Right.
When you're in the clinic and you're hustling and stuff, and you think about fertility.
Mhm.
Psychosocial support goes out the window.
Right. Especially because none of I don't know how it is at your institutions, but fertility is never covered by insurance. And a lot of patients have to decide whether they can even afford sperm banking or,
Yeah, every one of these things are done through philanthropy and
Yeah.
Yeah.
margin
Yeah, we
costs.
have that.
None of this is covered. Not only that, since we're now dealing with the adolescent patients, there are no FDA-approved drugs in children. And so every drug is a peer-to-peer authorization. Every drug is off-label use. Every drug is compassionate use from a drug company. It's really a problem that as an advocacy center, we have to think about the under 18s because every single thing is as if you're giving something wackadoodle to an adult.
I had one specific question for patient advocate on this topic. So previously, as part of prehab work, we actually implemented a standardized screening for mental health symptoms leading up to cystectomy, and we found like the prevalence is actually extremely low, but when we look at the overall bladder cancer population, specifically the survivorship population, depression, anxiety is very high. So we determined that maybe that was the wrong time for the intervention, but from your sort of patient journey, was there a time in which a screening intervention may have been more founded? Because it wasn't in our population 2 weeks before cystectomy, and you're referring, it's probably somewhere else down the road, so could you maybe share yours?
I appreciate that question because I actually
You mentioned it, yes,
noted
last
that
time,
to say before we ended this. I have two things I want to comment and impart to the practitioners in the room. One is, I mean, it was a weird time. It was COVID. We were all in our bubbles. Mental health was not a priority because they were all in this weird fog. Like I was just bumbling my way through this experience, just doing what I'm supposed to do. And I was lucky enough to have a successful business and family support. So financially speaking, I was going to hit my deductible and I could take off as many days as I wanted. Obviously, it's going to stress me out because the company has to run and I run the company. But there wasn't really much intervention on mental health. And at one point, I was just talking to my friends. One of my friends had like a anxiety attack, like a panic attack. It was a groomsman of mine. You know, nothing out of the ordinary like what was happening to me was happening to him, but he's just an adult going through COVID. And he's like, yeah, I've been going to therapy for this or that. And I go, why the hell am I not in therapy? I'm literally like, it's COVID, young guy with a rare cancer, what am I doing? And I was listening to a lot of podcasts at the time, so I just did BetterHelp, and I've been doing it for several years. And I'm like, oh my God, this has helped me so much with just tools to deal with just recognizing things half the time will make it go away, just realizing, oh, you're having anxiety about this. Okay, you've shown a light on it, now it just kind of disappears. So all of that has helped tremendously. So yes, I think just really any time the intervention would be helpful. Several interventions I would probably say, especially for just any age group. You know, in my experience, I'm struggling to get people in my family much older to focus on their mental health versus their physical health. I'm like, hey, your mental health is your health. Please focus on it because it's deteriorating. We can all see it. So all patients, many times, I would remind them that. The other thing is, I did a patient testimonial for it, and I think I brought it up yesterday, but the Signatera testing has done wonders for my anxiety because of that runway that it gives me. Like, I kind of want to stop doing CT scans because they're just tedious, and the billing always is weird, and I always have to say, reject the bill, and I have to bill it a different way, and it's just annoying. And I'm like, the Signatera, I can walk into almost any room and know that I have the least amount of cancer in that room because I have proof. I have the empirical data in my email. So I just know that if it comes back, I've got so much more runway. And so that's helped tremendously.
So that, I had a question kind of for the oncologists and urologists. Just at what point does cell-free DNA or urine-based DNA testing get to the point where you would be comfortable to use that, obviously in someone who has their bladder, instead of like a cystoscopy? Like, at what is the trade-off, or what is the point in which for long-term?
It's not there yet. No.
Your business.
No, seriously, it's not there yet. Not
No,
that.
yeah, but like, it was as a
question of negative predictive value.
Yeah.
Right?
Yeah.
So are you gonna, what negative predictive value are you gonna accept? Is 99% enough?
Yes, that's
right. So
No,
that's right.
Yeah.
You've talked about this before. It's like,
if
why?
you got a 1% chance of the test being wrong.
Yeah,
And I have a couple of patients like that.
Yeah, but I'm going to get another test in 8 weeks, so if that one's wrong.
Cover yours.
Yeah.
But I would say, there's also the Young-Onset test we looked at. The paper we did was looking at cell-free DNA in urine and the comprehensive genomic profiling and saying that you can actually predict a molecular recurrence, if you want to call it that. And so maybe you can decrease frequency of screening.
I think the point that
But it's
Brent.
like in that they got like, you can pull out a TERT mutation 10 years before, but are you going to intervene
What
if
will
you
you
see
do?
that versus kind of a tumor-informed
What will you, right.
versus a
Right,
tumor-informed,
what did
Say, Phil.
So let me make, I think that we're asking a couple different questions here. So I think the question that Jeff is asking is a cystoscopy hematuria screening test workup. That I think is much further. I agree with Ashish. Much further away. You mentioned, I think you're right, the CGP thing that with the Iranian cohort or whatever it was. So that's I purposely stayed out of that ballpark because to do that kind of study you have to have a 50,000 patient study, and you can't just like snap your fingers in that. But you can sort of snap your fingers and have like a cystectomy avoidance thing, which I think is where that's why we sort of position ourselves. So I think that question is a little bit different because there's just like anything, there's trade-offs, right? So maybe it doesn't have to be 99% accurate or whatever your metric is of sensitivity, specificity. We started kind of designing cohorts based on NPV, and I think now we're sort of more interested in accuracy. So, I think it's probably a question we would actually ask patients. Like if we told you that there was a urine test, rather than similar to like your blood test you had, your Signatera test, but it was for urine, and we could determine whether you had bladder cancer after you had a complete response after your chemotherapy. How accurate would the test have to be for you to say, I'm willing to roll the dice and not have my bladder taken out?
Or even to reduce to like in every other. So like if you cut the number of cystos in half and do, urine cysto, just to reduce down
Can I take the chairperson's prerogative? The breakout session for ctDNA is in gas lamp 1. Okay? No, seriously. I want to thank.
Part of it.
Absolutely. No, I don't disagree with that. But I think that brings me to what we want to do to wrap this up, right? So we don't want just to be a breakout session. We want it to be a working group, right? So for everyone, no. You will have a chance to speak, okay? Seriously, because I want everyone in the room to come about and tell us briefly, what do you want to see this group do for it to be a working group so we can actually do, we heard things about improving clinical trials, we heard about ctDNA. You can bring that up too.
So
we heard about
think the genetic thing, there's something we didn't, nobody.
Make sure it's recorded.
Okay. There's something that no one really talked about yet, and I talked about it a little bit with Brent, and that is the cosmic trinucleotide signatures. I feel like that's the lowest hanging fruit. If there are cohorts that have been sequenced, it seems like a very natural experiment to look for trinucleotide signature. I mean, maybe people have done that. I don't know.
The problem is with that cohort, you're going to need probably whole genome sequencing.
Right. Well,
so it's again, we have to get a gold standard, like a cohort together.
Yeah, I mean, I don't. You could have, you could look in the NC coffers, the MD Anderson coffers, the Cleveland Clinic, the Moffitt coffers, and the Fox Chase coffers, and we could probably put together a 100-patient cohort of patients who had cystectomy or had TURBTs or whatever, without maybe at least TURBTs pre-chemo, and look for. And we may not even find a new signature of an exposure or some bizarre exposure. You're skiing in a lake that's contaminated with dry cleaning, but like it could be. Sorry to reveal.
Possibly, I did. Yeah.
So, but yes, yeah, in the tissue, yeah. I mean, you're looking at but it may not even be a signature of a new exposure. It could also be like, do you guys have ApoBec? Like that, I'm like, do they have ApoBec? You probably don't have the same aging signature because you're only 35 and you got your tumor. So there's like a lot of things I think we could get from. Did you ever have your tumor sequenced?
I don't know if my tumor was, but I think I was sequenced.
No, your blood was sequenced, but I wonder if someone actually took a hunk of your tumor and actually put it.
For Signatera, they do.
Oh, that's right. That's right.
Well, they do a slight.
Oh, interesting. Oh, yeah.
So, but yeah. I mean, if we could get together.
Two different tumors, right? You had a small cell and a squamous, so were both sequenced for Signatera assay, or just one?
Great question. I have no idea.
That's a subtle detail you may not.
Okay.
Joshua?
Yeah, sir.
I think some of the questions you're bringing up about when we look at younger patients and more low grade, I think to have good comparisons, definitely defining what these cohorts are. Because part of me wonders, when you look at an overexpression of FGFR3, right, there you have a driver mutation promoting growth. Is that somebody who's just been found sooner because you have this tumor that actually grew and bled and did something, versus a lot of our patients, they probably do harbor these mutations. You need multi-hit or whatever it is. And so I think defining that clear age and then defining the groups who's going to be, is it grade, is it stage for stage, whatever it is, that's going to require a lot of patience to be able to do that, to get to it. And so I think probably finding a way to figure out what are the main questions, what's the low-hanging fruit, how do we draw these best comparisons, and then how do we share the data and what's already been done, so it's not a big sequencing effort going forward.
Can I make a second comment? So this actually reminds me. This actually reminds me of the Charlie Swanton lung cancer. So I mean, actually, now you said it out loud, it's exactly analogous. So, he's looked at young people, non-smoker. We talked about the non-smokers that get lung cancer. Yep. They get they tend to get driver hotspot, ALK, EGFR, and it just like FGFR3, And his thing is that those, what he's showing now, and I think very convincingly, is that these like particulate things that we're drinking or breathing, get lodged in your distal alveoli and are inflammatory. So you've got a hit with an inflammatory process, and that causes the cancer. And it wouldn't surprise me at all if you had an FGFR3 mutation with some microplastic or something we eat or drink that it is some sort of inflammatory hit, and it does the same thing. And yeah.
Thanks, Phil. I think sort of talking about the ctDNA, and there's a lot of escalation of therapy and a lot of guidance of therapy in the adjuvant setting now. I think one of the things that I'm interested in, I think a lot of potentially other urologists and urologic oncologists and oncologists overall, is de-escalation of therapy based on precision medicine, particularly on whatever the mutations are, ctDNA testing, and really being able to scale down what we provide patients in the neoadjuvant setting, because we're throwing a lot at patients beforehand and really being able to pinpoint who needs it and who doesn't need it.
If you can come to my poster. While I'm talking, I did ask questions of like what will you tolerate, like asking patient what will you tolerate in terms of margins of error, and I sent a survey that was really voluntary participation, so not so much of people that replied, but the answer is vary a lot. Like some people were surprisingly say like, I will tolerate to have like 2 years, let's say, metastasis-free survival of like 70%, and others were like, it has to be like 95%. So it depends so much of different people, but I would say a lot will be willing to take a bigger risk if that becomes spread about.
Yeah, you have to weigh it with, because for me it felt like, hey, we want you to live a long time. Let's hit it super hard. Let's remove let's go. We're gonna do everything. It didn't feel as much like, and I think it's because it was T3. Do you want to try this, or this, or do you want to try this first, and then if that doesn't work, try this. Like, we had a pretty clear path laid out for me. Again, it might have been because it was muscle invasive T3, but looking back, it was take the bladder, and that's it. And we're going to hit you with a lot of chemo.
So first, my working group goal is contingent upon us coming up with a consensus to define age of early onset bladder cancer. But then, specifically within that, looking at the group of patients like Brent who perhaps are not appropriate for organ sparing, what I would like to see, because I think we can learn probably from testis cancer, where we're used to dealing with a young population or pediatric populations or even early onset colorectal cancer, what are the 5 or 6 top priorities from survivors in terms of survivorship issues, whether it be fertility, sexual function, other things. I think there's a lot we don't know about what the first 5 years after cystectomy is like for early onset population, and I would suspect that it's going to be a different set of goals than in a population of 70 to 80 year olds.
I think my thought is, after listening to a lot of patients from the young onset about how difficult it is for them to be taken seriously, to have non-oncology providers to, do the appropriate tests, that what we can do with that information once we have a data set to have an age or to have better screening, how we can disseminate that to other providers so that patients don't go through 18 months of not knowing what's going on, how we can utilize that information to help providers not within oncology to be more aware.
So, as a medical oncologist, I'm very, after having 28 years as an oncologist, I'm very in tune with some of the topics that have been discussed with, especially regarding mental health in cancer patients, but especially in this young population, because they have to, older patients diagnosed at 75 or 70, they have to suffer mentally with the fact that they had cancer for maybe 15, 20 years. But for somebody who's diagnosed in their 30s or younger, they're living with the nightmare that the cancer might come back for 50, 60 years. That's a huge, deal. So I would, the mental health piece strikes me as being very important. And then one of the key things there is we actually have now virtual counseling that's available through Headspace and Talkspace. My company, for example, offers free Headspace and Talkspace for every employee. Okay, so it doesn't cost that much, and I think this is something that could be looked at perhaps through Beacon to offer a young bladder cancer patient population. It may be a pharma-funded Headspace for young adults with cancer under the age of whatever the cutoff is that we end up settling on. But it's something that's viable, it's feasible, and it can be, because just actually getting a mental health appointment with a professional is a nightmare in this country. Okay, insurance and other things like that don't always cover any of those things. So here I see an opportunity where, again, pharma-funded programs could help Beacon be the launch point for that.
I know Dr. Gupta and I are going to be talking at the end of August about how we can do more to really engage our young adult onset bladder cancer community and really get their input as well. So the working group combined with this group that we're intending to kind of pull together, I think can really make some big change.
Ekta?
What would you like to see come out of this working group? I had to think about that. Disclaimer, not a urologist or a medical oncologist. I'm a translational scientist, and I think I'm with you on wanting to elucidate all of the genomic, epigenomic, all of the different biological changes. And so I would love to see us identify a way for a consortium, identify a way to consent all these young patients that are coming into clinic to provide samples, provide tissue, build a biorepository of that we can study alongside some of our, diagnostic partners and pharma partners, and really start to identify new targets and even causes of disease. And is that something that you think patients would be interested in? You could rally the patients and be like, that hospital has my tissue, send it to this consortium, and just start building that database. That's not something that I've heard anyone have access to, and we're scrapping it all together, which, don't get me wrong, I'm very resourceful, but I think we could do this in a more systematic way.
There's a rare GE malignancy group or working group already. I mean, considering the age distribution, maybe that could be just as part of the rare GE malignancy. Sure.
Okay, I'll ask my question first before I. When you see younger patients, I think I read a couple of reports, scattered or isolated reports, where it was mentioned younger patients are hesitant to go through cystoscopy, or they are more nervous. So does that allow disease to progress or become more aggressive? Is that one of the associations? As anyone noticed? Like it's just a couple of papers that have reported like why it's aggressive in younger patients. Because they are hesitant.
I think the papers have reported that younger patients have a delay in being referred to the urologist.
Yeah.
Absolutely. And whether it's because they are afraid or the PCP is afraid or if there's some lack of awareness, we don't know. Once they see the urologist, there's not that much delay to actually having the appropriate diagnostic procedure. So the lead time is them getting to the right specialist.
Right. Okay, that was my question. I think my point is awareness. It's still not, young people don't know what bladder cancer is. I mean, as much as older, also not all. Like it's as your the survey that the World Bladder Cancer, a lot of people don't even know what bladder cancer is. So I think that's awareness needs to go like breast and prostate. There's so much advocacy and awareness for breast and other cancers that are more prevalent. I think that needs to go to schools, because I have a 16-year-old going to 17 soon. I think their school, I hear the conversations, they don't even know what bladder cancer, and she just keeps telling me, what if I put a mascara, oh, you're telling me I'm putting cancer on my, because I say, why do you put it every day? So I think they are not aware of cancer in general. Plus something like bladder cancer is kind of very far, right? Now we are seeing an increase. So I think some awareness in schools, outreach and all is necessary, as we do for reproductive and sexual health related issues.
Especially with e-cigarette.
Yes, exactly. Yeah. So they are not aware as much, I think. And coming to the mutations that you have identified, I mean, this question was discussed quite well before about the differences, females and males, and I think you do see KDM6A and FGFR, STAG2, which is more common in females. So are you seeing that in younger females too? It's not the case.
I've not separated out by male and female. My guess is, again, getting to a power issue of like, you have so few cases to begin with that when you take 10% or 20% of one person, take a quarter of their bladders.
Okay. Hello everyone. I'm from the researcher background, so I would like to highlight some points from my opinion about the initiation of the bladder cancer basically. So for me, I think that the genetic instability is the major factor for the initiation of the bladder cancer. It could be because of the exposure of the chemicals or because of the knockout or mutation on the certain genes, because in my opinion, when we work on the mouse models and if we induce particular knockout or mutation in certain genes in the early age, that also give rise to the bladder cancer compared to the ones which are exposed to the BBN and then they develop like a cancer in a longer duration, not like that faster as we are like targeting specifically to the particular genes. So basically the exposure also leads to the similar kind of like a accumulation of mutations which happens with like a time, and it takes longer time than the particular mutations which occurs in the early stages. So when we talk about the early onset of bladder cancer, I would say that it requires completely specific attention and requires a lot of sequencing and genomic studies to identify different targets to it's a completely different disease for my opinion, because if we talk about the pediatric disease like pediatric AML or adult AML, they are completely different. So I think that the elderly disease and the adult disease could be the completely different and requires more attention.
I think this is just the beginning. It's our first session. As we move forward, we'll start dwelling into the regular 71-year-old median age versus. So lots of great ideas. We only have 3 more minutes and we don't want to keep you from your evening plans. Any other burning questions or suggestions for next year? Would love to welcome.
Akshay?
I guess 2 comments. One is that I think it'll be interesting to first kind of map out the natural history, as we have learned from the young onset colorectal cancer. We don't know if it's just the same disease in younger patients or if it's different biology. So I think putting together a practical group of patients, maybe 50 or something, and actually looking at their outcomes just to map out the natural history. And the second thing, I think what Brent mentioned in his talk yesterday, that I feel like always hesitant to give patients questionnaires because I feel they don't really fill out the questionnaires. But he said that he never got that 900 questionnaire. So I think the younger patients may be more motivated to fill out these questionnaires, so we may actually learn the risk factors and things. So that would be another point.
Sometimes you get a gift card, so.
Anyone else? Anyone else going once? Going twice? One. Okay, we have 2. One there and one there.
There are some that are sometimes pregnant.
I heard pregnant, and that's going in the direction of my question, is for the young women and, maybe not seeing the symptoms like the video that we got to see. Is there a way to do partnerships with GYNs so that once they've rolled out everything else that could be going on from a reproductive standpoint, is make sure your next step is to maybe either a referral to a urologist or do a simple test or like ultrasound or something. That's my only thought on that.
Thank you.
Okay, Omar?
Omar, you get it.
Yeah, so I think in my practice I've been doing germline testing on patients, and I'm not sure if it was mentioned, but it's never been rewarding. The MVTA assay, it's always negative, but it's a non-informative negative. And there are other companies that do offer a deeper germline testing. And I think it would be good to maybe invite some of those companies that are doing a deeper dive into these germline testings and basically have them compete on who is going to do a deeper dive, because I do think it's a multi-factorial issue, but it does have some germline prong to it, exposure, environment, diet, etc.
Thank you. That's a great point.
Okay,
yes,
one
Mike?
last one.
Mike.
I think this was a great session. I've been to a bunch of these bladder cancer sessions over the years, so my only comment was I think you should continue.
Thank you.
Okay.